Good morning. Welcome to our panel on quality and practice transformation efforts nationwide. It is my great pleasure to introduce my two good friends, Van Lee, who is the Director of Business Development and Measures Management for the New Jersey Innovation Institute, which is the state-designated entity for health information exchange in New Jersey. And Van is also affiliated with the Regional Extension Center in New Jersey as Director of Technical Services for NJ High Tech. Also joining us on the panel today as a national figure in quality measures is Dr. Kevin Larsen, who is currently the Medical Director for Meaningful Use at the ONC HHS and is a part of the CMS Lean implementation efforts. Kevin is a general internist and a specialist in medical informatics and serves as the Chief Medical Informatics Officer at Hennepin County Medical Center for many years and was involved in authoring the clinical quality measures for meaningful use. So Kevin, I believe you're up first, and then Van, and then I'll have a few slides at the end.
It's really exciting to be here. Thank you very much. As David mentioned, I've moved now from ONC to CMS, so actually I'm no longer at ONC for about a month, and I'm a full-time CMS employee. And my work there is both as a health IT consultant to the Innovation Center and also to implement lean process improvement system-wide across CMS, which is a fun and exciting new project. I've been asked to speak about the future directions from a national standpoint on quality measurement. And that can go in a lot of different directions. I've got some thoughts here. I don't have any slides, so you can look at the really nice picture of Michigan there. So one of the first things I think to speak about is this really exciting and bold commitment that the U.S. government made about a year ago now, a year and a half ago. The Secretary, with support of the President, made a commitment that 90% of all CMS payments will be linked to quality by the end of 2018. That's unusual for a number of reasons. The government doesn't often set its own performance targets, and here the government set its own performance targets, and one administration set performance targets that would move into the next administration. It's also bold for how big a change that is from where we used to be. So 90% of the payments of CMS will be linked to performance targets. That's pretty impressive. Additionally, 50% of payments will be in value-based payment models. And so what we know is paying for reporting or paying for just having some measurement is a nice first step to get infrastructure built, to get people motivated. But the real changes in quality and outcomes happen when people actually are incentivized and have some money on the line to incorporate that into their systems. So I guess my first point here is that value-based payment is coming, at least from a federal standpoint. It's really clear that we've made a strong commitment and we're actually a long ways towards our target. We're further ahead on the target than we expected. Most of you likely know about the MACRA legislation that is currently out as a proposed rule. The Medicare and CHIP Reauthorization Act is what MACRA stands for. It has as a big centerpiece of it the merit-based incentive payment system, or also known as MIPS. Because it's under proposed rulemaking, we can't take clarifying questions about it. I can explain a little bit of what is in the proposed rule, but if things aren't clear or you think there should be changes, we really encourage you to write those as suggestions back to us. We take those suggestions very seriously, and we look at those suggestions. We want the rule to be clear, we want it to be understandable, and we want it to work. And so please send those comments in to the rule. The components, I'll get a little bit into that, but it's not just coming the MIPS program primarily covers ambulatory fee-for-service providers. Now, that is bigger than the meaningful use providers that have been out there. It's more like the PQRS set of providers that are there. It's potentially 1.2 million providers that will be eligible for this merit-based incentive payment system. So it will cover a number of other providers who can bill under fee-for-service, nutritionists, therapists, anyone who's been billing under fee-for-service outpatient for CMS as an individual provider will be covered potentially by the MIPS program. It does not cover things like institutions those that have individual programs. Other ways that value-based payment is coming from Medicare, the Impact Act was passed a couple of years ago, and some of you may be familiar with this. This continues to connect and link the types of performance goals and targets of institutions like nursing homes, post-acute rehab facilities, and eventually, potentially even hospitals, to collect and share the same kind of functional status and other kinds of patient-centered data and move that across those organizations. The Centers for Medicare and Medicaid Innovation, CMMI, as we heard this morning from Dr. Kendrick in the programs like the Comprehensive Primary Care Initiative, CPC, are very much focusing on quality as a key component of these new payment models that CMMI is rolling out. So if you have been paying attention to the new joint replacement bundle that is recently launched, the joint replacement bundle has as a component value-based payment so that you have quality measures as a part of that program. And as part of the Affordable Care Act, CMS has been standing up a host of value-based payment programs for all of its fee-for-service programs. So nearly every one of them now has a quality payment program tied to it. Things like end-stage renal disease, hospice, ambulatory surgery, et cetera. This has led to what many people think of as a kind of sea of measures and a sea of measurement programs. And that's because they've been tied to the payment systems that we have. And so each payment system that goes to a site of care tends to have a measurement and value-based payment system tied to that place. So if you function independently as an ambulatory surgical center, it seems pretty constrained. You're only doing this ambulatory surgery. If you're a large health system like I used to work in, then it feels like, wow, we have a whole lot of measures because each one of our different lines of business now has an independent measurement program because we now are responsible for all of those under our system. So what's coming in MACRA and MIPS? We'll be talking a little bit more in depth about this tomorrow. But the 4 components that will make up the measure-based incentive payment system program are quality reporting. That's one of the cornerstones. Another one is what's called advancing care information. And this is the meaningful use, the former meaningful use section. It's now been made much more flexible with the proposed rule has no longer threshold-based measures. It's kind of a sliding scale of performance, so it's not an all or nothing. There's also an efficiency section and a continuous practice improvement section. And the continuous practice improvement is there to incentivize people that do practice improvement and quality improvement activities of numerous types. Again, read the rule. There's a lot of stuff written out there, and please send your feedback to us. So we're making it happen. We're making it happen in part because Congress has asked us to through things like MACRA, MIPS, and Impact, also because there's a commitment from the Department of Health and Human Services. But what should people be doing with it? What we're seeing in the most kind of successful places is that the measures actually drive your business and they drive your practice. What do I mean by that? How do you know that you're having success as a clinician? I'm an internist. How do I know that my patients are getting better? How do I know that my investments and my care coordination and other activities are actually better this year than they are last year? Without some visibility into my practice and the things I care about in my practice, it's really hard to know that the improvements I'm doing are actually making things better. What we know from industry is that industries that are able to put in consistent metrics that they can track performance to and use to drive their business are the businesses that succeed. Imagine Amazon achieving the kind of real-time or next day, same day delivery without tracking how long it takes for them to deliver things. It's nearly impossible to imagine them building that kind of a system without knowing and being able to take all those incremental steps to make that improvement. So the goal of measures here is not accountability. That's one of the, I think, side benefits. To my mind, the primary goal here is, as a doctor, I should know that my practice is getting better. I should know that my care is getting better. I should know that I'm learning and growing and making it more health. And so some of the characteristics of measures that do that in industry and healthcare and other places are that you have access to the data, you trust your data, and that it's on things that are meaningful to you as a provider. Also that the data is as near to real time as you can have it. One of the challenges we've had with healthcare data for a long time is the lagging nature of the measures that we get. An analogy I like to give is, imagine you have a car and your car has no dashboard. You don't have a odometer, you don't have a speedometer, you don't have a gas gauge, and you drive your car for a year, and at the end of the year, you send some chip into the government, and a year later, the government sends you back a letter in the mail, snail mail, and says, by the way, last year, your average speed was 65 miles an hour. That was too fast. Please go slower next year. That's much like the kind of data feedback most clinicians have been getting about their practices. Part of the reason we as clinicians don't find value in them is because of their very lagging nature and the fact that they're not actionable. When Dr. Kendrick showed the work that they're doing in Tulsa about making that data patient-centered across the whole community, so that I don't feel like I'm missing some information that I was quite sure that the patient had, because I have a whole community view, and I can turn it into actionable care gaps that I can build a plan around. I can prioritize my time, I can prioritize my staff time, I can build a work queue for a case manager to say, here are the care gaps we're focused on this year, this is our year for diabetes, or this is our year for blood pressure, and so therefore I want you to make these phone calls to these patients to make this happen. And because you're measuring in real time, you can see week to week or month to month, depending on the speed you want to look, are you actually making improvement in that care gap? That's the vision, that's the goal for what we're doing here. A lot of the work we've been doing in the government is trying to build the marketplace and the standards of the infrastructure to make this happen. But the goal is not to make everybody do it the same way. I think we need standards in order for you to be able to do what Dr. Kendrick did. If every practice just invented their own measures, it would be impossible to pool them across the community. It would be impossible to roll them up and down between various lenses. So we need to set some standards to figure out how we can share them. But then we also know that they work best if you do a further step and make them really useful to you as a practice, which may be some modification, it may be a slight change, it may be some things you ignore, other things you add. But at the core, that standard helps us be able to use these in multiple ways, in multiple dimensions at the same time. One of the big trends that's happening nationally is a move to outcomes. And a lot of people talk about this, but I think it's helpful to get really concrete. What do we mean by an outcome? And I think when you start kind of pushing on that, you get a different definition by different people. The goal, I think, is fantastic, but the achievement is pretty hard. If we're honest with ourselves in healthcare, at least where I practiced, we didn't really measure outcomes. We measured care processes. And we didn't really know what happened to a patient after their surgery. I didn't really know what happened to a patient after my visit because I didn't have a system that assured that somehow I captured the data that they had no complications of their surgery. I didn't have a system that made sure I knew that the patient actually had a controlled blood pressure 6 months after their visit with me. So the move to outcomes, to my mind, is going to challenge all of us to find new ways to be sure that we're routinely capturing the data, the information that we need for outcomes, because very often we're not doing that. And because, again, to Dr. Kendrick's slides, often the outcome or the other care is happening in someplace else. It's going to continue to stretch us to build these partnerships so that we can routinely get that information from the next place at hand. I think case in point is hospitals and primary care doctors. They're each going to be measuring outcomes for each other. The hospital is going to discharge a patient and not know what happened. The primary care doctor may know what happened to that patient because they were seen in primary care. The primary care doctor is going to manage a chronic disease, and the patient may die in the hospital. The hospital, therefore, is going to know the outcome of the primary care doctor's work. So we're going to have to continue to figure out how we share data and how we collect things in a standardized way so we know what those outcomes are. One of the things that I see the most interest in are patient-reported outcomes. So patient-reported outcomes tend to be standardized survey instruments that have been well validated to say this is how a patient is doing. I think the one most people are familiar with is the PHQ-9, which is a measure of depression and depression outcomes. Another one that has a lot of traction is measures around functional status outcomes after hip and knee surgery. So these are standardized questionnaires that ask on a scale, what's your function? And you measure it before the surgery, and then you measure it typically 9 to 12 months after the surgery to know if the patient actually improved. They're used routinely in the United Kingdom. They're used routinely in many parts of the US, but they're not used routinely across the US. There are many of these patient-reported outcomes, and I am seeing a lot of interest in a lot of different places to capture them. In fact, partners in Boston, the Harvard Medical System has for about 4 years been on a journey to capture patient-reported outcomes for every patient in every practice type throughout all of partners. So places are making an investment to figure out how this works, not just in a little one-off place, but across their whole system. What are the benefits of patient-reported outcomes? Well, we get to see this outcome. It's also something really meaningful to consumers because people understand function. That's something they value and want out of their surgery. They may not understand some of the things that we have defined as outcomes in the past, surgical complication rates or certain kinds of lab test results. Those are harder to translate to people than I actually can walk better, and people like me walk better after we've had this surgery. Another one of the trends that's coming, and it's been happening in advance of the MACRA MIPS legislation, but it's also called out in MACRA and MIPS, is the ability to, I'm going to call it build your own measures. So if anyone has looked at or become a QCDR, a Qualified Clinical Data Registry for the PQRS program, the Physician Quality Reporting System, this was a new option about 2 years ago in the Physician Quality Reporting System, that instead of using the pool of government pre-approved measures in the PQRS program, you could sign up with a registry, typically a specialty society or a physician-led registry, that had a history of measuring yourselves and creating measures within your practices or within your specialty. And those measures then you would submit to the government and say, we're going to measure the providers across our specialty, their providers in our registry group, and these are the measures that we propose. There are some really terrific examples of where this has proven a lot of value. I think one of the ones that's most advanced, and a lot of others are looking to model, is called the IRIS registry. It's the registry of the ophthalmologists. This registry has nearly half of the ophthalmologists already signed up for the registry and using the data. They take and work with the registry's electronic health record, or excuse me, the practice's electronic health record, and they do a real-time live connection with that EHR, and they source the data directly into the registry for measuring outcomes of eye surgeries. They've developed, I think, about 12 measures now within this registry, and they measure things like return to the OR after cataract surgery, visual improvement after cataract surgery, the kinds of things that eye doctors value and trust, and because it's done by the Eye Doctor Professional Society, they have a lot of trust in those measures. We've also heard stories that it's been really powerful for those practices. So an example of this is a practice that looked at this measure of return to the OR after cataract surgery, and they were a practice of 10 doctors, and they saw that one of their doctors had a much higher return rate to the OR than the other 9 did. And they said, gee, we never knew this before. And they went and met with that one doctor, a good doctor. They liked him and trusted him. And through some internal work of figuring out what was different between his practice and the rest, the next year he had the same low rate that all the rest of the other 9 doctors had. This is the kind of visibility and real-time data that lets you understand where your own practice variation is as an individual or a group, and lets you figure out how you can solve problems as a group that are valuable. People don't want to go back to the OR after they had their eye surgery. So there are many, many of these registries now standing up, some of which are in primary care, and many of them which are in specialties. One of the other trends, I think, and the things coming here into the future is that these are becoming electronic. Like I mentioned with the eye registry, that is electronic feed to and from the practice. That's a lot of the work that we are focused on as electronic quality measures in this standardized way. And so that takes the burden, the cost out of the human chart abstraction and gathering of these measures. And I think the last thing I'll focus on as I wrap up and let the others speak is a new focus on group accountability, and this is a hard one. A lot of us are used to a fee-for-service model where I know exactly what I'm accountable for, and those are the things that I do. But I think many of us are aware that it's only through working as a team of providers and in a coordinated way will we actually make the kinds of improvements and the kinds of care outcomes that our patients want. So I'm hearing from many payers and many patients that they want us to take team responsibility for an outcome of a patient. How does that team responsibility work? That's, I think, a lot of the stuff we have to figure out. Some of the proposals are for us to be able to report quality reporting on a group level instead of on an individual level. At first blush, that's going to sound appealing. As you lift the covers, you're going to realize there's some complexities in there because the way we attribute measures individual, at least in the PQRS program, is how many visits you've had with a patient, and it has to be more than one. All of a sudden, if you have a group of 10 of you, if that patient is seen 2 of you each one time, now you could potentially be accountable as a group for each seeing that patient once, when before, when it's one at a time and you only saw the patient once, you're not considered accountable. I think one of the most radical proposals about group accountability that has been considered by CMS is to make a quality measure in which hospitals would get a value-based payment for the smoking rate in their geographic area. This is saying that hospitals would have an accountability not just to the people in their hospital, but an accountability because they're often a big employer and a big economic and health leader in their community to actually help drive the community-based smoking rates. In abstraction, for somebody else, it sounds great. When you start to think about what would that mean for me, there's a lot of challenges. But this group and team accountability is one of the big trends that's coming. With that, I'll close and look forward to questions with you. This is really exciting. You guys are doing terrific work here.
Morning, everybody. Sorry, got it. Good morning. Firstly, I want to thank Tim Pletcher and, of course, Jeff Livesay for inviting me to speak, inviting New Jersey Innovation Institute to come speak to you all. And it's really a great honor and privilege to be speaking with such great thought leaders and innovators in this space of health IT, and it's really exciting from my perspective, who worked on industrial engineering and from a different industry, coming into healthcare and trying to really look at the different technologies and the different aspects that we're trying to cover here at Health IT. So again, my name is Van Lee. I'm the Director of Business Development and Measures Management for New Jersey. And I have about 27 slides to go through in 15 minutes, so it's going to be fun. Bear with me, please. And from a contextual perspective, I want to give you all an idea of who New Jersey is. Of course, we're in Michigan, so I want to give you an idea of what New Jersey is, what we've done, and who the Innovation Institute really is. And then I'll really get into kind of a pitch. Really, what is this quality? What is this value? Because from a provider perspective, which is where we grew from, that's really all the questions that they're really asking. And then to cap it all off, we were awarded a $50 million CMS Practice Transformation Grant to really put this all together. So I wanted to highlight that. So at the beginning, I want to start in 2010. We were a regional extension center, like Jeff did mention, where we were able to actually move and help support over 9,000 primary care physicians and specialists from switching over to paper, from paper into an electronic health record, certified EMR system, and then ultimately achieving meaningful use. And that program still exists today, even though it was a 5-year program from 2010, and obviously it's finished now. We're also a health information exchange. We represent 5 inner-city urban area hospitals, Medicaid heavy, as an HIE exchange. And since 2012, we are actually been providing services for population health. And in 2012, we created a tool to actually help our Medicare Share Savings ACOs ease the burden really of reporting, which I think all of you have are on the front lines and help support as well. And in that same year in 2012, we became a CMS qualified registry. And this helped us really support the physicians in the quality reporting space in PQRS, where we are covering 300 plus measures over 40 different specialties. And what I really want to highlight here too is in 2015, believe it or not, Governor Chris Christie designated us as the state health designated entity for health IT. And that really helped us connect with Jeff Livesay and MiHIN in establishing this network of networks in New Jersey, which is really sorely needed, especially in the work that you all are participating in. And then, of course, finally, we did receive that award, which really kind of brings us all together from the ambulatory outpatient perspective and really the HIEs. So I'm going to start with really quantity over quality, right? Fee for service. And many of you kind of know these facts, but it's really important when you're speaking to physicians, and now we're in the age of this transformation, that they kind of understand the why. So fee for service really is rewarding quantity over quality. And simply put, more visits, more tests equated to more dollars for the physician community. And this is a tough mentality to kind of break when we're on the front lines trying to convince providers to adjust and to transform and to really kind of do more work in their practice. So let's just start with looking at some of the facts. First, there are more people entering the program from Medicare perspective. In 1966, there were 19.1 million beneficiaries, and in 2013, that jumped up to 52 million. And in 2030, it's expected to inflate up to 80 million folks in the Medicare beneficiary world. Another fact, the second fact, is that these folks are also living longer and are facing a growing number of chronic conditions. When Medicare started in 1965, the average age was 70 years old, or the lifespan, and in 2010, it was 78.7. And it's also important to note that in terms of chronic conditions, 94% of the Medicare expenditures involve individuals with multiple chronic conditions. And to kind of put a cost dollar to it, in 2010, these Medicare beneficiaries with 6 or more chronic conditions accounted for half of Medicare's $446 billion in spending. And the third fact that I'm going to present to you all is chronic conditions, as a fact, is requiring coordination of care. But currently in the fee-for-service world, which I think you all know, there's no real reward for coordination of care. And another supporting factor to this is approximately 75%, and this is the challenge, beneficiaries continue to receive coverage through fee-for-service. And so a change is kind of needed, but it's been gradual. So let's take a look at kind of the roadmap, and some of this has been reviewed yesterday as well, and some today. But there's really 4 categories, and the Healthcare Payment Learning and Action Network really put a great illustration out there in terms of the different categories of healthcare delivery reform happening now. Where category 1 is fee-for-service, there's no linkage to value or quality. And then in jumping up to category 4, it's really population-based payment, for example, capitation. So there is a strategy, and I believe Kelly Cronin did share this with you all yesterday, and Dr. Larsen did mention this as well, in terms of the strategy and the goals of HHS, where from 2016 to 2018, we're looking at the shift from payments being linked to quality and value, moving from 85% over to 90%. And then, of course, the alternative payment models, or ACOs, they're looking to shift that from 30% over to 50% by 2018. So let's look at now, how are these programs being implemented? So if you look at category 1, obviously there's no real linkage to quality and value. Looking at category 2, there's a fundamental foundational payments made for infrastructure and operations. That, to me, is meaningful use, and to all of you, you've been participating in those meaningful use programs. Next is then pay for reporting, and this is where Physician Quality Reporting System, or PQRS, comes in. And then finally, when you look at rewards for performance or negative adjustments for performance, that's where the value-based modifier comes in. And I'll go into an example of quality and cost scoring a little bit further into the slides. And then category 3, which really is the APMs, or alternative payment models, and where there's upside gain sharing and there's downside risk as well. That's where Medicare Share Savings comes in. In 2017, we're looking at the next generation ACOs as well, which you all should be familiar with. And then ultimately in category 4, this is where Comprehensive Primary Care Initiatives, or CPC Plus, which is the new CPC coming up, where again, capitation. So these are some of the examples of how you have the foundation set up. These are the categories, the strategy in terms of the goals, and these are the programs that our providers or physicians or hospitals are facing and are participating in towards these specific goals. So now let's look into an example of quality and cost scoring. I'm going to go into a specific graph here, and this is a comparison of really a provider's or a physician's quality and cost compared to their own colleagues' quality and cost, where on the y-axis you're looking at the cost, and then on the x-axis is the quality. So it's important that providers and physicians and practices understand that this is how you're going to be judged in terms of the payments and reimbursements that come down the line for performance. And so this next slide kind of goes into the matrix. What is the matrix and formula for these particular adjustments? And I'm going to use 2016, and this is again based off of 2014 reporting. So whatever data you report in 2014 are going to be that data is going to be used to adjust your payments for 2016. So, and on the top right axis, of course, is where you get the maximum dollars, and on the lower left side of the quadrant is where you get the penalties and the adjustments, hence the red and the greens. What's important to note here is that X variable that's in there. It's called the adjustment factor, which is determined by CMS's own analysis, and this is the comparison of colleagues' data. But if you look at 2016, the X factor or adjustment factor in 2016 was 15.92%. So let's use a real-life example of an organization that we supported, a 300 medical group earning $50 million in Part B Medicare billing. And they had scored through PQRS reporting or through Registry reporting. They were judged as high quality and average cost. So looking at that matrix, they would fall into the 1X category, or 15.92%. So taking their billing of $50 million times that with 15.92%, they were actually able to earn an additional $7.96 million off of that $50 million that they earned. So this was a fantastic call that we received from our practices, but they asked, how did we earn this? How did we get this? And the follow-up call naturally was, well, if I had actually been a low-cost group, I could have earned 2 times that 15.92%. So that's a really big eye-opener, and obviously significant when it comes to the dollar values there. And then, of course, vice versa, there's also negative adjustments, right? If you're not performing when it comes to low quality and then high cost, you're going to be negatively adjusted, right? And this is a fact, and this is what's been happening. And this is based off of the 2014 reporting and the adjustments happening in your 2016 billing. So fast forward just to 2015, and this is going to happen next year on your 2017 billing. This is just an example. I don't know what the adjustment factor is, but if it's 10%, I think we all understand the math and multiplying that. But what here is worth noting, though, is that the matrix is multiplied by a factor of 2. So you can see when you achieve the high quality and then low cost side, it's 4 times the X factor. And this is information that is made public. It's on CMS's website, but a lot of providers and practices who are involved and see Medicare patients are not really understanding or not really aware of this yet. So I swear to you, I wish Dr. Larsen and I did coordinate on this, but I'm going to now break into an analogy. And it's literally the highway analogy that Dr. Larsen was talking about. But this is, for New Jerseyans, we call this, I'll use the New Jersey Turnpike. For Michiganders, I don't know what your major highway is, but I think, you can replace whatever the highway is, and the analogy still goes. So our physicians are in a world where they're traveling down this turnpike or whatever it is, and they're asked to exit on measure. Okay, great. You can exit on measure. Where's the exit? How far am I from that exit? These are the things that you're immediately asked, right? Now I'm asked to monitor. I'm asked to manage these exits and get there. How do I get there? I don't know how far I'm going. I don't know where it's going. I don't know where my trajectory is. So there's this nifty invention, and Dr. Larsen mentioned this as well, called a dash. So what we've been doing in New Jersey is building these dashboards, and these dashboards are important, and it comes from rich, accurate, and clean data, which is really what health IT is really all about, right, in terms of that rich and clean data. So now that you have a dashboard on process, on performance, and again, relate these measures, monitor, and manage to MIPS, VBR, VBM, value-based modifier, excuse me, or ACO, or any of the categories that a provider participates in. But now you put these dashboards, now you can see, okay, I'm gonna exit here, I'm only a few miles away, I need to adjust my processes here, I need to adjust my cost here. That's why that dash is extremely important, right? So this segues into what our approach really is when it comes to helping practices in terms of quality and cost, and how these tools really support our practices. Participating. So really what we've really become a bridge. When you look at the programs that our providers are participating in, and the timeline is listed below in terms of all these programs that they have to get towards or they have to exit to, some of our clients are on the left. What we do is act as kind of that bridge. And our methodology, and to get through this bridge, you need to achieve high quality and lower cost of care, which ultimately does earn you more incentives. And really for New Jerseyans, it's that 7.96 number was really great for a 300 medical group, but these extra dollars just kind of keeps the business open as well. When you think about the primary care providers dealing with large number of Medicaid patients, which we deal with in the Newark, New Jersey area, it's just really about keeping the door open as well. And these new value-based care, if they're not prepared, they could end up losing their business beyond just practicing medicine, right? So under this TCPI grant, which we, again, were able to earn, we're able to support these providers and physicians and hospitals in navigating through all these specific programs that are out there. So what really is this grant, and what are our efforts in New Jersey to make this change and to really support our providers? It is a $50 million collaborative agreement. And what I want to highlight here is that our grant takes us from October 2015 on through September of 2019. And this really kind of dovetails perfectly into MIPS. So we kind of see this grant as a real opportunity to help our providers navigate through MIPS, achieve the MIPS goals right in time for when MIPS really gets implemented, which is in 2019, but again, using that analogy of 2014 to 2016, they're really gonna have to perform really in 2017, which is only a few months away, right? And what's not on that slide is we do have our goal of also saving the health system $250 million, which is really part of some of the goals that we have under our program. But essentially our services, we are creating a network. This is a practice transformation network that is really based off of weekly, monthly, some frequent level of quality reporting and cost reporting, right? Back to that dashboard. If I need to get to value-based modifier, if I want to earn those positive rewards and adjustments and avoid the negative adjustments, I need to know where I'm going. I need those dashboards. I need to know how many staff do I need to look at. I need to know who are my populations that I'm targeting. And then another component of our services that we're providing in New Jersey is on-site transformation coaching. And it's really important, that distinction of coaching. Michigan is a big sports state, and I've grown up in high school participating in sports, and I always think about my coaches. And the coaches are our mentors. They're the ones that sit us in the room afterwards, force us to look at tapes, force us to look at our flaws and critique us, only to help us, right? And so our on-site coaches are designed to do that, and they're called coaches for a reason. So these dashboards, these tapes, these real-life tapes that the providers can see, what our coaches will do is bring in the best practices, help them adjust, help them in terms of health IT support or in terms of practice transformation support, really get them to that next level so that they can perform better, right? And then ultimately, we're looking at, obviously, to earn these upward adjustments and avoiding penalties for our providers. And in line with our the HHS goals, we're looking to graduate them into Category 3 and Category 4, which we're going to call graduation. You know, we come from a school in New Jersey Institute of Technology, so we're still thinking that school mentality and really calling it graduation into the next level. And so, in terms of I'm going to share with you now our measures methodology and how we kind of accomplish these specific goals. And it's pretty simple. I think you all have gone through it, but it's really good to kind of just illustrate and reiterate. You know, first you look at who's my target population? Who are my heavy cost hitters? And then two, what are the measures? What measures do they fall into? Are they the diabetics? Are they the obese? Are they the COPD, CAD patients that I'm looking at? Because you can't really manage what you can't measure, right? And then, of course, next is who, how, and when will I be reporting this, right? There are timelines attached to PQRS. There are timelines attached to ACO reporting and whatnot that really comes in and adjusts your payments. So it's really important to understand who, how, and when are you reporting on this specific information. And then finally, did it work, right? You want to go back and be able to see. This is back to the coaching, back to the rewatching your tape. Did it work? You want to provide them with the dashboards. You want to provide them with the specific provider, patient level report so that they can close in specific gaps in care. They can curb negative behaviors, but also with these dashboards, they can also highlight best practices. So it's really critical that our measures methodology and the methodology that we've adopted in New Jersey really kind of follow this particular map that we created. And so in the essence of time, this is just, we want to reiterate the clear goals that we have, you know, when it comes to cost and quality. When you're looking at high cost and low quality, you're looking at overutilization, potentially preventable. Fee-for-service world is here, and there's some fragmentation. And then and lack of cost transparency. When you move into the high quality and lower cost, you're looking at value compared to volume. You're looking at MIPS, the value-based modifier, performance and quality, and then ultimately, of course, the alternative payment models that HHS and really the payments are going to be moved into this perspective. And so from a technology perspective, so that was kind of our measures methodology and the education from a technology perspective. We kind of like what Michigan is doing and many of the folks that are supporting these particular programs. We want to ease the burden of reporting. We want to ease the burden of that through one data pool, one data extraction, and then reporting on all. PQRS, meaningful use, ACO, DISRIP, or our practice transformation network. Again, this is really how we can support our providers through the different disparate EHR systems that are out there, the fact that providers some of them are not on EMR systems, or their systems are not able to document the specific quality metrics that are pertinent to a particular population and can really improve the overall population's outcomes and care. And this is by far my favorite slide to deliver to all of our customers and physicians because it's free. We're not charging our providers, we're not charging our hospitalists, we're not charging any of the members that are join our program because CMS has paid for it. So we're going to be providing free ongoing education, webinars, and guidance for these value-based programs. We're going to be providing ongoing quarterly assessments from a practice transformation perspective to these practices and delivering that information right back. Again, we're really all about transparency when it comes to data. We're going to provide free gaps in care support and measures performance analysis. This is that dash that we're talking about while they're traveling through the turnpike or whatever highway here in Michigan. Free PQS reporting, right? We want to be able to tell them that you've done this work and now there's rewards and incentives behind that. And that's where the PQS reporting comes in when it comes to our program. And of course the coaching. We've built a team of coaches that will go out there and coach cohorts of practices together to bring out, again, highlight best practices and curve negative behaviors that ultimately impact your quality and cost scoring and your bottom line. So we ended up, and just because it's New Jersey, and just for you all to know, this is a CMS program, and so those folks that are in Medicare Shared Savings ACOs, unfortunately, are excluded from our program. So what we've been able to do is actually branch out across the country, and you know, with technology, obviously the advancements of technology, we've been able to provide services across the country regardless of where you are. And in New Jersey right now, just to give you a kind of an understanding of where we are, we have 800 providers signed up, and that's covering about 270,000 lives. Again, we have about 28 ACOs in our state. But we've been able to reach out to Louisiana, Maryland, Puerto Rico, and Hawaii for our work and to join our program. And so if you look at kind of just what our current status is and the services that we provide through our program, we've been able to really, as a PTN or our Practice Transformation Network, again, looking at quality data registry, being able to reward providers and giving them a module to be able to send this information to CMS. Quality and cost performance comparisons. We're able to, again, deliver this information to all of the providers that participate in the program. Data sharing is critical. I think that's been spoken about. It is critical, and data analysis is also important. And it's really from a physician solo or 1 to 3 provider practice. They won't have the ability to do the analysis themselves. So at this point, that's where we're really seeing our value when it comes to the providers. And of course, master patient index with the help of MiHIN and management. And so right now, this is my final slide. We have 9,000 total providers signed up. A little bit over 3 million lives are being covered here. And again, I just want to reiterate, you know, we do have a $250 million cost reduction goal. So we're looking at best practices and interventions to help, again, in these cost savings. I do apologize, I don't have a kind of a final slide with my contact information in there, but I'll be here for the rest of the day, and that's really it for me. Thank you all.
So at this exact moment in time, I'm wishing that my slides were before Van's because I don't have the cool PlayStation sort of animation, but here we go. I'm Jeff Livesay. I'm the Associate Director for MiHIN, and I'm going to talk about quality measure reporting, and I have to ask you a question. For Dr. Kendrick's presentation, I'm so sorry that I missed it. I was upstairs with Dr. DeSalvo's workshop. Did Dr. Kendrick explain how they're calculating quality measures from CCDAs and go through all of that? I'm seeing a few nods. Okay, so in Michigan, our approach has been very different. We have not focused on the calculation of the measures, but on the reporting of the quality measures, and that's an important difference. And just quick background, very quick background. In 2013, my boss, Tim Pletcher, said, I want you to go and talk to Jason Werner about this ONC Trailblazers project. And my head was already sort of spinning. And he said, I want you to talk to him about these QRDAs that are a part of the HQMF. And I thought to myself, now that's just great. my head was already about to explode, and now he gives me a bunch of new acronyms I've got to learn, and they all consist of high-value Scrabble letters. And so I started trying to learn, and Jason and Tim slowly taught me. And one thing that Jason pointed out that I'll never forget is that one day in the future, we're going to have a tsunami of quality measures, and we need a standard way to transport those and report them in this QRDA, Quality Reporting Document Architecture format. Well, you know, the quality measure world is kind of a mess today. Van showed you how New Jersey has made a lot of sense out of it, but there's not really a current national standard way for sending quality measures to the different reporting systems. States like New Jersey are doing workarounds. Today in Michigan, measures are sent manually to state Medicaid and other quality monitoring reporting programs, and there's a lot of repetitive work. You have to report individually to each program. And it means logging into different systems. There's a lot of workflow. They have to manually send to request their meaningful use credit. And it's just not very neat. And so we focused on building an architecture that would reduce the burden of workflow. You heard Van talk about that. You heard Kevin talk about that. You heard some on that yesterday. And we also wanted to align the high-value measures because there are like 7 or 8 measure sets now, and I think there are just a handful of measures that intersect in all the measure sets. If you come to the quality workshop tomorrow, you'll see Bo present a Venn diagram that's really great to show that overlap between the measure sets. So we focused on the alignment and building one statewide service that will accept all measure types. But we started with the meaningful use, 93 clinical quality measures for meaningful use. And we wanted to have a report once capability, which Van also talked about, so that physicians and their EHRs could send the quality measures one time, and then we would take care of the rest, okay? And so that's what we're going to show you, and that's how we reduce the workflow burden on providers for all this quality reporting. Now, if you take Van's diagram of their infrastructure and turn it like this. This is the national ONC quality data reporting model. On the left or on the top of Van's diagram, you have data sources, EHRs and other sources of quality data. In the middle, you have some kind of a transport service, some kind of a data router. Here, it's our statewide health information network, MiHIN, and our skimmer, clinical quality measure reporting and repository service. That accepts and validates the data and then sends it to all the places it needs to go. And on the right, or on the bottom of Van's slide, you see the data receivers, Medicaid or CMS, the PQRS. Physicians want to look at their own measures that they have reported. HIEs, the state data warehouse, health plans, all want to be able to either receive or look at that quality data. This is a general model that works for all quality measures. So we built the skimmer service, and it receives and validates and quality checks and organizes and stores and forwards clinical quality measures from any measure set. And so in the interest of time, I'm just going to show you how that works. Here's my animation. It's not way cool like Van's, but here we go. On the left, according to that architecture I showed you, you have the data sources, and they generate the QRDA files. These are just XML files. That's all they are, but they're big and complex. And they can send them to MiHIN either through one of our statewide HIEs. We have 10 HIEs in Michigan connected, or they can simply attach it to a direct secure message and send it to an inbox like cat3 at direct.mihin.org or cat1 at direct.mihin.org, and we strip off that payload and then we throw the direct message away. We don't need it anymore. In fact, that part can be automated within the EHR using just some simple API calls to your direct HISP so that there is zero provider workflow. We call that automagical. And so, thank you. And so once we receive the QRDA files from any measure set, we bring them into Skimmer and we do validation, quality checks. We look up the NPI number, that's the National Provider Identity Number, in our statewide provider directory. And then if they're Cat 1s, we can convert to Cat 3s or other formats as necessary. And then the final step, what Jason set us out on in 2013, the actual reporting. Send it to state Medicaid. Send it to Medicare via the PQRS. We're a PQRS certified registry. Send it to the Medicaid payers. Make it available in a portal or a data mart to physicians and health plans. So this is, these are the receivers on the right-hand side of that general architecture or the bottom of Van's version of that. So that's basically how the quality reporting works in Michigan. And we can use this for the PPQC that you heard about yesterday or any quality reporting program. So there's the architecture. Data sources on the left, data router in the middle, data receivers on the right. Okay, simple, dimple. And then what you can do is you can have dashboards, again, not as cool as Kevin and Van's dashboards. By the way, Kevin, in my imagination, your slides were awesome. So here you have 3 providers that are compared across 4 measures at the bottom. And you can see the yellows and reds. Each of those providers has some room for improvement in some of their measures, okay? And this is going to affect how they get paid. So if you see yellow and red in your measures, or maybe a practice manager in the clinic sees the yellow or red for one of their physicians, they want to act upon that and try to close those gaps in care. We have to cut a little bit short for a stage change, but the benefits are that you automate the workflow, you decrease the labor costs for data collection, there's report once to send to multiple destinations, you easily can earn your MU credit. We can automate that once we receive a valid Cat 3 or Cat 1, and eliminate your costs for having multiple connections, which is kind of silly if you think about it. And so then you have the ability to do analysis and improvement opportunities. And the dashboard example that Kevin used to tell me is, imagine you had a car that had no speedometer, and you get a report from the Secretary of State once per year. It said your average speed last year was 65 miles an hour. You need to slow down. That would be useless. And so reporting a quality measure once per year is not useless, but it's kind of like that, getting the speed, your average speed once per year. And so we wanted to build a service that was sticky, that providers would want to send measures more often, even if they're not Medicaid or Medicare, okay, because it helps them improve their quality. And instead of a have to make it a want to. So that was one of our objectives. So here are some of the other benefits. It's a little repetitive. Thank you very much for your time. We have about a minute for questions. Thank you.
We are all reading about the new quality measure process for CMS that's been proposed. There's approximately 200 measures. Each clinician pulls out approximately 6. There's subcategories of measures. But on a population basis, should we be pulling in all 200 and assessing population level performance using sort of a global quality index and collecting all of this on a statewide data multi-payer? Is that how we should be approaching this challenge to create the needed infrastructure? And I think that relates to what Jeff's last slides might be implying. What are your thoughts on this?
So I can take this. A lot of others' thoughts too. I think there are, define what your goal is. So one goal is to have infrastructure that's fast and easy to use and changeable. And that's the kind of reason to use these standards, is because you build then an infrastructure that you could repeatedly use for lots of different reasons and lots of different purposes. And when the measures change or the priorities change, you don't have to rebuild a new infrastructure. You actually use the infrastructure you have, and you're able to do that. So part of the vision here is, if you do this with the standards, which might be a little harder, eventually it makes it easier because everything is able to be done in those standards. So that's one reason, and that gives you visibility into lots of different patient types, and lots of different providers can find value. Something else, though, if you're talking about what should Michigan be tracking for Michigan, many would argue 200 measures is too much to track to be able to say, are we making progress? And so there's a nice Institute of Medicine report about what's called Vital Signs, Core Metrics for the Nation, which is looking at what should be the list of things we track as a health system, as a state, as nationally, to know we're making the kind of progress we want to make. You can build composites. A lot of those are sort of challenging us to do kind of some compositing. But 1,000 different numbers isn't likely going to give visibility to your legislature, your governor, your providers to say we've made progress as a state or not, unless you do some kind of clarification, alignment, and potentially compositing.
What Kevin said, I agree with what Kevin said. So we're out of time for the next panel. Thank you very much. Please help me thank our panelists.